Imagine you, or someone you care about, has had surgery to fix problems with their blood vessels, maybe using a clever bypass or perhaps a stent to hold things open.
Hmm.
Doctors often call these devices grafts or endografts. They're absolutely essential for tackling serious issues like aneurysms or, stubborn blockages.
They really are vital
But
tools.
now picture this. One of these critical implanted devices gets infected. It's not just a simple setback, it's a serious, complex challenge.
It absolutely is.
Today, we are plunging into a deep dive into exactly this topic, the world of vascular graft and endograft infections.
That's right. And these infections are notoriously difficult to manage. And surprisingly, until very recently, there wasn't one single unified set of clear instructions guiding doctors across Europe on the very best ways to handle them.
Really, so practice is varied.
Significantly, yes.
Which is precisely why our source material for this deep dive is so incredibly important. It's the first ever comprehensive clinical practice guidelines, specifically for managing these infections, put together by the European Society for Vascular Surgery in 2020.
Exactly. Think of this document as the experts finally saying, okay, let's pull together everything we know and give everyone a clear roadmap.
Our mission today is to walk you through this significant document and extract the most important insights for you. Whether you're a patient currently living with a vascular graft, a caregiver for someone who does, or simply someone fascinated by the intricate challenges of modern medicine, we want to give you the crucial knowledge distilled from these pages.
We're going to look at what these infections actually are, figure out who might be more vulnerable,
Right.
explore how doctors use clever tools like imaging and lab tests to pinpoint an infection,
How they find it.
delve into the often complicated treatment options, and perhaps most crucially, we'll share what patients themselves felt about navigating this challenging experience.
It's about giving you a solid foundation of knowledge, understanding the complexities involved in the medical decision-making, and truly appreciating the human perspective when facing these serious conditions.
Exactly, understanding all sides of it.
Okay, let's unpack this then. First things first, what exactly are these vascular grafts and endografts we're talking about? Could you paint us a picture?
Sure. Think of them as, well, replacement parts or maybe internal scaffolding for damaged blood vessels, mostly arteries.
Okay.
Vascular grafts are typically tubes made of strong synthetic materials like polyethylene, terephthalate, or expanded polytetrafluoroethylene.
Right.
They're put in place during open surgery, often like creating a new road around let's say, a traffic jam in the vessel.
A bypass.
Precisely. Endografts are a bit different. They're fabric tubes supported by a metal framework, a stent, and they're usually delivered from inside the vessel using tiny incisions, sort of reinforcing a weak spot or patching a tear from within.
Less invasive.
Generally, yes. They're essential tools for repairing things like ballooning arteries called aneurysms or bypassing long blockages.
And so a vascular graft or endograft infection is literally when one of these implanted medical devices gets invaded by bacteria or other tiny germs.
Exactly that. It's a critical, though thankfully not an everyday complication.
Okay.
The chance of it happening varies, depending on the specific type of graft and where it's located in the body. But when it does occur, it's very serious.
How common is it, roughly?
Well, for example, the source mentions that infections in prosthetic bypasses placed in the leg might occur in up to 2.8% of cases.
That number might sound small, but as you said, the potential consequences are significant. So who is more likely to encounter this challenge? What puts someone at a higher risk?
The guidelines highlight several factors. It's kind of a mix of things about the patient's overall health and things related to the procedure itself. On the patient side, risks include being overweight, having diabetes where blood sugar isn't tightly controlled, or having chronic lung disease.
So having other health battles already makes it potentially tougher to fight off an infection.
Precisely, yes. Then there are risks tied directly to the surgery.
Such as?
These include things like having emergency surgery rather than a planned one, spending a prolonged time in the operating room, maybe having infections elsewhere in the body at the time of the procedure,
Right.
or experiencing complications with the wound healing afterward, like surgical site infections, collections of blood called hematomas, or fluid collections called seromas.
I see.
Even needing a subsequent reintervention or, unfortunately, a major amputation nearby can increase the risk.
Okay, so if an infection is suspected, how do doctors actually determine if a graft or endograft is infected? It sounds like the signs might not always be, shouting from the rooftops.
You are absolutely right. The way these infections show up, the clinical presentation can vary hugely.
Oh.
Well, at one end of the spectrum, it might be something as seemingly minor as redness, or maybe a little discharge from the surgical wound.
Okay.
At the other end, it could be a life-threatening, system-wide reaction to infection called sepsis, or even dangerous bleeding.
So the symptoms aren't always a clear signpost pointing right to the graft itself.
Not always, no. Sometimes the only clues might be a fever that doesn't have an obvious source, or perhaps an unexplained increase in the body's white blood cells, or elevated levels of an inflammation marker called C-reactive protein.
Interesting.
Other times, the infection might manifest more obviously as pockets of pus known as abscesses, or infected blood clots that travel through the bloodstream, septic emboli,
Wow.
or even abnormal tunnels that form between the infected graft and nearby organs like the bowel or airway. These are called fistulas.
This important document brings up something called the MAGIC criteria. What's that all about?
Ah, yes. The Management of Aortic Graft Infection Collaboration, or MAGIC. They developed a standardized way to help doctors diagnose these infections, particularly in the aorta, that large artery in the abdomen.
A checklist.
Sort of. It's a list of major and minor findings based on a patient's clinical signs, what doctors see on imaging tests, and results from laboratory tests.
Can you give an example?
Sure. For instance, finding pus right around the graft during surgery, which is then confirmed by examining it, that's considered a major criterion.
Okay.
Another major one is actually recovering the specific germ that caused the infection from a sample of the device itself after it's been removed.
So it's like gathering different pieces of a medical puzzle to confirm the diagnosis.
Exactly. A very good analogy. The guidelines strongly recommend a thorough evaluation using these criteria whenever infection is suspected.
Right.
And what's really crucial here is the emphasis on identifying the specific microorganism causing the infection whenever possible. This is usually done by taking samples for testing.
How are these samples taken?
Yeah.
And where from?
Well, ideally, the very best samples are taken directly from the site of the suspected infection, often during surgery if that happens.
Okay.
The guidelines suggest taking at least 3 samples from deep within the affected area, not just, say, a swab from the surface.
Why deep?
Because those deep samples are much more likely to accurately find the specific germ causing the trouble. Surface swabs can sometimes just pick up contaminants.
Makes sense.
And ideally, samples are taken before any antibiotics are started, as the antibiotics can make it harder to grow the bacteria in the lab.
Ah, right.
The document even mentions using a technique called sonication on the graft material itself.
Sonication.
Yeah, it uses sound waves to basically shake loose any bacteria that might be hiding in a sticky layer, a biofilm, on the graft surface. Helps improve detection.
Clever.
Yeah.
And what kinds of germs are typically involved in these infections?
Well, gram-positive bacteria are the most common culprits. These include types of Staphylococcus, like Staphylococcus aureus, and also those often found on the skin, like coagulus-negative Staphylococci, Staphylococcus epidermidis, for instance.
Okay.
But gram-negative bacteria and other types of microbes can also be involved. Knowing the specific germ is absolutely key for choosing the right antibiotic treatment.
Right.
And the source points out that some organisms, like Staphylococcus aureus, are considered more, let's say, virulent. They're unfortunately associated with a higher risk of the infection coming back compared to others.
Beyond looking at symptoms and using lab tests, imaging sounds incredibly important for actually seeing where the infection is located and how extensive it might be. What tools do doctors use to get this visual?
Imaging is indeed absolutely essential. Ultrasound can be a useful first look, particularly for grafts closer to the surface, like maybe those in the legs.
Okay.
You might see collections of fluid around the graft, for example. However, ultrasound has significant limitations.
Such as?
Especially with grafts deeper in the body or in patients who are obese. The view can just be obscured. The guidelines actually state that using ultrasound alone is simply not recommended for diagnosing these infections.
Okay, so ultrasound is maybe a starting point, but definitely not the full picture. What's typically the next step in imaging?
Computed tomography, angiography, or CTA is usually recommended as the first-line imaging test.
How does that work?
This uses X-rays and a special contrast dye injected into the bloodstream to create very detailed pictures of the blood vessels and all the tissues surrounding them.
And what are they looking for?
Doctors are looking for telltale signs like pockets of fluid or even gas around the graft that shouldn't be there, or maybe thickening of the walls of nearby bowel loops or those abnormal connections, the fistulas we discussed earlier.
That sounds like it provides a much sharper, more detailed view.
It certainly does, but even CTA isn't perfect at definitively proving or ruling out an infection. Yes, sometimes even with CTA, the findings just aren't completely clear. In those situations, or perhaps if CTA can't be done for some reason, magnetic resonance angiography, or MRA, might be considered.
How is MRA different?
MRA uses magnetic fields and radio waves to create images. It provides slightly different information about the soft tissues, which can sometimes be helpful in clarifying things.
And the source also mentions nuclear imaging techniques, like specialized scans using TAG white blood cells or peaky scans.
Yes, exactly. These are very valuable tools, particularly when the diagnosis is still uncertain after CTA.
Tell me about P scans.
Okay, so positron emission tomography, or PT, often combined with a CT scan PT-CT, works by showing areas in the body with high metabolic activity.
Metabolic activity.
Yeah, since infection and inflammation involve cells that are metabolically very active, working hard, a PET scan can essentially light up hotspots where the body is actively fighting off a potential infection.
I see. And the white blood cell scans.
Right. White blood cell scintigraphy, that's another type of nuclear test where a patient's own white blood cells are carefully labeled with a tiny amount of radioactive material and then put back into their bloodstream.
Okay.
White blood cells naturally rush to sites of infection, so imaging the body shows where these tag cells accumulated, pinpoints the infection site.
What's particularly useful about these nuclear imaging techniques?
Well, their ability to show whether the actual graft material itself is actively involved in the infection, that can be tricky to determine just from CTA alone sometimes.
Right.
So, for suspected infections in the limbs, white blood cell scintigraphy, if it's available, is recommended as an additional tool. For grafts in the chest or abdomen, PT-CT is recommended if the findings from CTA aren't conclusive.
It's almost always better to prevent a problem from happening in the first place than to have to treat it.
Yeah.
What do these guidelines say about trying to avoid these infections?
Prevention is definitely a critical focus, and several strategies are highlighted. Interestingly, while the guidelines mention there isn't strong evidence that one type of synthetic graft material, like polyethylene terephthalate versus expanded polytetrafluoroethylene, is inherently more resistant to infection than another. Certain practices can significantly lower the risk.
Like what? Are we talking simple steps or more complex interventions?
Both, actually. Simple but important things include making sure the patient is kept warm during surgery,
Okay.
proper hair removal the day before the procedure, and maintaining rigorous sterile technique in the operating room. Really strict cleanliness.
The basics.
The critical basics. But one of the most impactful strategies is the use of antibiotics given around the time of surgery.
That's called antibiotic prophylaxis, isn't it?
Yes, exactly. Giving systemic antibiotics intravenously before the procedure starts is a powerful way to significantly reduce the risk of both surgical wound infections and those potentially devastating early graft infections.
How strong is the recommendation for that?
This is a Class 1 recommendation. That means there is strong evidence supporting its benefit, and experts agree it should be standard practice.
Okay.
The antibiotics are chosen to target the types of bacteria most commonly associated with these infections, typically bacteria like Staphylococcus and Streptococcus.
And how long are they given for?
The guidelines note that extending this antibiotic cover for more than 24 hours doesn't seem to provide additional benefit, so it's usually just around the time of the surgery itself.
What's truly fascinating here is a recommendation that might seem a bit out of the blue. Considering eliminating potential sources of infection before the surgery, especially focusing on dental issues.
Dental problems. How are someone's teeth connected to a vascular graft in their leg or, their abdomen?
It sounds unrelated, but it's a less obvious but really important link.
How so?
Bacteria from the mouth can sometimes enter the bloodstream, particularly during certain dental procedures that involve manipulating the gums or the root of the tooth, or procedures that might cause bleeding.
Oh.
So for patients who already have vascular grafts, the guidelines recommend considering giving them antibiotic prophylaxis before specific dental work.
Like a preventative dose of antibiotics.
Exactly. This is similar to recommendations for patients with artificial heart valves, for example. It's a Class 2A recommendation.
Meaning the evidence leans towards it being useful.
Yes, suggesting the weight of evidence leans in favor of its usefulness. It's a great example of how infections can sometimes originate from seemingly unrelated parts of the body.
That is fascinating.
All right, so even with the best prevention efforts, infections can sometimes still occur. This sounds like where things become incredibly complex for both patients and doctors. How do doctors approach treating an infected vascular graft or endograft?
It is definitely very complex, and the guidelines make a very strong recommendation here.
What's that?
Patients suspected of having or confirmed to have one of these infections should ideally be transferred to a specialized, high-volume hospital, one with a multidisciplinary team.
A team approach.
Absolutely. This team would include vascular surgeons, infectious disease specialists, radiologists, and other experts working together. Managing these infections really requires a coordinated approach.
And that's a strong recommendation.
Yes, this is a Class 1 recommendation, emphasizing that expert team-based care is essential for the best outcomes.
Okay. What else?
Antibiotic therapy is also recommended for every single patient with an infected graft. That's another Class 1 recommendation.
So antibiotics are always part of the plan.
Always. Often for a very long time, sometimes even lifelong, depending on the situation.
So getting to a center with a team of experts and starting antibiotics are the absolute baseline. What about dealing with the infected graft material itself? That seems like the core issue.
That's the core of the surgical challenge, absolutely.
Mhm.
For patients who are medically fit enough to undergo major surgery, the ideal and most definitive treatment is usually to completely remove all the infected graft material.
The whole thing.
Yes, and any surrounding infected tissue. Think of it as needing to thoroughly clean out the entire contaminated site.
How strong is that recommendation?
This is a Class 1 recommendation specifically for abdominal aortic infections, supported by strong evidence.
Okay, but you can't simply take out the graft and leave a gap where a major blood vessel should be, right? Blood flow needs to be restored.
Exactly. That's the next crucial step. And this is where the surgical options become quite varied, and the choice depends heavily on where the infection is located and the patient's overall health and condition.
What are the main ways they rebuild the blood vessel pathway after removing the infected part?
There are two primary surgical strategies outlined in the guidelines.
Okay, what's the first?
First, there's what's called in situ reconstruction.
In situ, meaning in the same place.
Exactly. This means putting a new bypass or graft back in the exact same anatomical location as the infected one was.
But isn't that risky, putting something new into an infected area?
It is, which is why this is only done after aggressively cleaning out the area debridement, removing all the infected tissue first. It has to be a clean bed.
And what do they use for the new graft?
The guidelines discuss using different materials. One option is using the patient's own veins. Think of borrowing a healthy vein from somewhere else in the body, often the leg.
Using your own tissue.
Yes, which can be more resistant to future infection. Other options include using specially preserved donor arteries or veins from tissue banks called cryopreserved allografts, or even certain types of treated synthetic grafts, like those coated with silver or soaked in antibiotics like rifampicin before being implanted.
Lots of options.
Yes, the choice often depends on the location of the graft, the specific type of bacteria causing the infection, and the patient's condition. Using the patient's own vein is often preferred when possible, especially for certain infections or in younger patients.
Okay.
And importantly, covering this new reconstruction with healthy tissue, like a nearby muscle flap or tissue from inside the abdomen called omentum, is also recommended when feasible, particularly in the abdomen. It helps protect the new graft.
Like an extra layer of protection.
Exactly. So that's in situ reconstruction, direct replacement after a deep clean.
What's the other main approach?
The second approach is called extra-anatomic reconstruction.
Extra-anatomic, meaning outside the normal path.
Precisely. This involves creating a bypass away from the infected area. The new graft is tunneled through clean, healthy tissue, completely avoiding the original infected site.
Can you give an example?
Sure. If an infected graft is in the main artery in the abdomen, the aorta, a bypass might be created from an artery in the arm routed down outside the abdomen, connecting to the arteries in the legs.
Taking a detour around the problem area.
A detour through clean territory, yes. This strategy avoids placing a new graft directly into a potentially contaminated field.
What's the downside?
Well, these extra-anatomic bypasses can sometimes have lower long-term success rates in terms of staying open and keeping blood flowing compared to in-situ repairs.
It really sounds like doctors are carefully weighing the risk of the new repair getting infected against the complexity and the long-term success rates of rebuilding the blood vessel pathway in different ways. A tough balancing act.
It absolutely is a very complex decision tailored to each patient.
Are there other options besides these big surgeries?
Well, there's the possibility of conservative treatment, This usually involves lifelong antibiotics and potentially procedures to drain any fluid collections around the graft.
Does that work?
For infections involving the aorta or grafts in the abdomen, this is rarely a permanent solution. Unfortunately, it carries high risks of ongoing infection or serious bleeding down the line.
So when might it be used?
It's generally only considered for patients who are simply too unwell, too frail to tolerate major surgery.
Okay.
Using techniques like percutaneous drainage, inserting a tube through the skin to drain fluid, might be used temporarily, maybe to help identify the germ or reduce the bacterial load,
Right.
but usually not as the final definitive treatment. This is considered a Class 2B recommendation, meaning its usefulness as a standalone treatment is less well established compared to surgery.
What about using an endograft in an emergency situation, especially if there's severe bleeding from the infected site?
Yes, that's another scenario the guidelines address. In life-threatening emergencies with active bleeding, placing an endograft inside the vessel can sometimes be considered as a temporary measure.
To stop the bleeding quickly.
Exactly, to control the bleeding and stabilize the patient. Think of it as a bridge treatment to buy critical time when things are really unstable.
But it's not the final fix.
Generally not. The guidelines strongly emphasize that this is usually not a definitive solution because the infected graft material and surrounding infected tissue are still left inside the body.
So the infection source is still there.
Precisely. Once the patient is stable enough, a full surgical procedure to remove the infected material and reconstruct the blood vessel is often still needed for a durable, long-term result.
What's the recommendation level for that bridging approach?
It's generally a Class 2A or Class 2B recommendation, depending on the specific location. This highlights that while it can be a life-saving temporizing step, it doesn't typically solve the underlying infection issue long-term.
Thanks for clarifying those recommendation classes, Class 1, 2A, 2B. It helps understand the strength of the advice.
Yes, Class 1 means strong evidence and agreement. Class 2A leans toward useful, Class 2B less established, and Class 3 would mean not useful or potentially harmful.
One of the most compelling parts of this document is that it wasn't just written by doctors in isolation. It included direct input from patients who had actually lived through these infections. What did the experts learn from listening to the patient perspective? This feels incredibly important for anyone listening who might be a patient or caring for someone who is.
This section provides truly invaluable insights, I agree. It's a real highlight of the guidelines. Patients who had gone through a vascular graft or endograft infection shared their experiences, and their feedback really pinpointed several key areas where communication and the care pathway could be significantly improved.
What specific points did they raise that stood out to you?
Well, a major point was about the information provided before the initial surgery where the graft was placed in the first place.
Before the infection happened?
Yes. Patients felt they weren't given enough clear, understandable information about the actual risk of infection. Or, even if they were told about the risk, they didn't fully grasp just how serious a vascular graft infection would be, and how involved, painful, and difficult the treatment and recovery process would be if it did happen.
So really understanding the potential severity and the impact up front was lacking.
That seemed to be a common feeling, yes. Another significant challenge patients described was the management after they were diagnosed with the infection.
What was the issue there?
They often felt they were moved between different hospital departments, maybe from vascular surgery to infectious disease, perhaps to intensive care and back.
Right.
Which made it hard to have a consistent doctor they connected with, a single point person, or even just a clear understanding of their overall treatment plan and what the next steps were going to be.
Feeling a bit bounced around or lost in a complex system during a really stressful time?
That's a great way to put it. That feeling of being lost came through. Patients also expressed that they simply weren't adequately prepared for the complexity of it all, or the significant pain involved, or just the sheer exhaustion that comes with treating these infections. Nor were they fully prepared for the critical need for very close and often long-term follow-up care after treatment finished.
So based on this direct patient feedback, what suggestions did the guidelines make for improvement?
They offered clear suggestions. They recommend that vascular surgeons need to provide more precise and understandable information about the risks of these infections, explaining clearly what it means and entails, even for procedures that seem less invasive, like endovascular ones.
Better upfront communication.
Definitely. There's also a recognized need for better education for general practitioners, the family doctors.
Why them?
So they are more aware of the infection risks and are better equipped to suspect a graft or endograft infection once a patient has gone home and presents with certain symptoms. Early recognition is key.
And having that dedicated point person you mentioned seems crucial based on their feedback.
Yes, absolutely. The feedback highlighted that doctors involved in the care should be more mindful of the need for a dedicated referring physician or a consistent point person.
Someone to coordinate and communicate.
Exactly. Someone to keep patients well informed about their current status, the progression of the infection, and the overall plan for their management. This consistent, empathetic communication is clearly very important to patients navigating this really challenging journey.
It's clear these guidelines represent a huge step forward, pulling together the best current knowledge and, crucially, including those patient experiences. But even with such a comprehensive document, are there still areas where the experts feel more research is needed? Unanswered questions looming.
Oh, absolutely. The guidelines themselves are very open about this. They state that this is a field that changes rapidly, and there are many aspects of managing these infections where robust, high-level evidence is still lacking.
Where does the current knowledge mostly come from then?
Much of the current understanding comes from looking back at past cases, retrospective studies, or from smaller series of patients treated at single hospitals. Not from large, randomized clinical trials, which are really considered the gold standard for generating strong medical evidence.
So this raises an important question for the future. How do we gather better evidence to make even clearer and more definitive recommendations down the line?
That's exactly the challenge.
What are some of the big unanswered questions they point to that still need research?
Well, the guidelines specifically list several areas. For instance, we need more data on the actual risk of serious complications like brain abscesses when infections involve the arteries in the neck and upper chest. That's not fully understood.
Okay. What else?
There's also a need for better evaluation of certain specific treatment techniques, like using particular vacuum-assisted wound closure systems, or whether drainage and irrigation alone can ever truly be an effective primary treatment option outside of very specific limited circumstances.
So confirming which less invasive approaches truly work, and when and for whom.
Yes, exactly. And more evidence is needed on the effectiveness of using emergency endografts as that temporary bridge treatment we discussed, understanding when it's most appropriate and what the real long-term outcomes are after that approach.
Right.
There's also a practical question about which antiseptic solutions are truly the best for irrigation during surgery when cleaning out the infection. The current evidence just isn't strong enough to make a definitive recommendation on that yet.
So how do they propose getting answers to these questions?
The authors conclude that to really answer these questions and build a stronger foundation for future guidelines, there's a critical need for large, multi-hospital registries.
Registry.
Yes, databases where information on patients with these infections is collected in a standardized way using predefined variables as they are treated going forward prospectively.
What would that achieve?
This type of prospective data collection would allow doctors to make much better comparisons between different management options and ultimately lead to stronger, more evidence-based recommendations in the future.
Wow, that was a truly in-depth look into a really complex and critical topic in vascular surgery, drawing directly from these important European guidelines. We've covered a lot.
We certainly have.
From defining what these vascular graft and endograft infections are, understanding who might be at higher risk, how doctors diagnose them using signs, symptoms, detailed imaging, and microbiology. Through the often intricate surgical and antibiotic treatment strategies, and importantly, we've heard the invaluable perspectives of the patients who have gone through these challenging experiences.
It's clear that managing these infections requires a high level of specialized expertise, definitely a coordinated team approach, and these guidelines provide a much-needed framework for medical professionals across Europe, aiming to standardize and improve care.
And it's also powerfully clear that the patient voice is pushing for crucial improvements in communication, clarity about the risks involved, and, well, a more streamlined, consistent path through the healthcare system when facing such a serious complication.
Absolutely. That message came through loud and clear.
Ultimately, while significant progress has certainly been made in understanding and managing these infections, as the guidelines themselves highlight, there are still many unresolved issues in areas that urgently need more research to improve outcomes and the patient experience even further.
That's the ongoing challenge.
So what does all this mean for you listening? If you or someone you care about have a vascular graft or endograft, knowing about the potential, albeit often low, risk of infection,
Mm-hmm.
being aware of the signs to look out for, understanding the importance of seeking care at a specialized center with a team, and having open, clear communication with your medical team is incredibly valuable information.
Knowledge is definitely power in this situation.
And it leaves us with this thought. Despite the remarkable advancements in surgical techniques and the development of comprehensive guidelines like these, the persistent challenge posed by tiny microorganisms causing infections in implanted medical devices remains.
It really does.
It's a powerful reminder of the ongoing need for medical innovation, for robust research to fill those knowledge gaps we discussed, and, perhaps most importantly, for genuinely patient-centered care that acknowledges not just the technical challenge, but the human experience of navigating such a serious condition.